So this is the forum's opening session. So we know we have many people here with very diverse backgrounds, knowledge, particularly in the area of AI. I know myself, I have a very baseline knowledge of what artificial intelligence is, especially when we talk about AI in the context of health. So the purpose of this panel really is to establish a strong foundation for understanding the very complex and evolving issues surrounding artificial intelligence in health. And our plan is to really anchor our discussions in a couple of timely and real-world case studies that highlight important benefits, risks, and considerations that are relevant to our panelists' expertise and lived experience. And we're hoping this panel will be very interactive. We'll invite audience participation throughout. Hopefully everyone knows how to use Slido. We tested that out. And we'll have time for Q&A at the end. So I'm very happy to introduce our panelists today. I'll start with Dr. Amol Verma. He's a physician and scientist at St. Michael's Hospital in Toronto. He co-founded and co-leads GEMINI, which is Canada's largest hospital clinical data research network. And in the realm of AI, he really focuses on applying AI within the clinical healthcare setting. Charlotte, right next to me, is a member of HDRN Canada's Public Advisory Council. She is a co-author of opioid-related research publications. She advises on drug policies and sits on a number of advisory boards, including the AI for Public Health Community Advisory Board. And finally, last but not least, Dr. Marta Maslej. She is a staff scientist with the Krembil Center for Neuroinformatics at the Center for Addiction and Mental Health. And within the realm of AI, she really focuses on applications of AI in mental health, as well as equity considerations. So we'd like to start off with a little audience temperature check. We're going to ask you all a couple of questions. The first question is, and so get your Slido ready if you can, what are you most excited about when you think about the role of artificial intelligence in health? We're going to try to have a word cloud, and usually that works best if you kind of put 2 or 3 word answers. But what makes you really excited about, what the capabilities of artificial intelligence are in healthcare? Efficiency is a very big one coming up, and I think we'll talk about that with our panelists for sure. I see cost savings. Okay, innovation is another one that's coming up. Real world data, saving lives, scaling, wait times, that's a big one. Rare disease diagnosis, so a lot around diagnoses. Ethics, and we might talk a little bit about that today in terms of the ethical issues surrounding AI and health, both positive and negative. Reducing burden. We'll certainly touch on that when we explore our first case study. Personalized medicine, that one's coming up there as well. So it looks like things are slowing down. So thanks everyone for those responses. Now let's have a little bit of a contrast. What are you most worried about when it comes to the role of artificial intelligence in health? What kind of scares you about it? Bias, privacy, and ethics again. I see a lot about data breaches, privacy, security, errors, misinformation. I think we can all agree that's a big one, especially today. I see world domination. Not wrong, it's possible. Yeah, so a lot around equity, bias, reinforcing inequality, humanity. Yeah, the kind of the loss of human and humanity. I see the Matrix, too. Hallucinations, yeah, that's a good one. Okay, so it seems like things are starting to slow down, but it's great because I think we are going to touch on many of these issues that have been raised today and throughout in this session and throughout the rest of the day as well. So let's start with our first case study. We're going to talk a little bit about AI and medical scribes in healthcare. So medical scribes can be considered one of the most widely implemented applications of AI in medicine today. So what do we mean by medical scribes? So simply put, these are programs that record and transcribe conversations between clinicians and patients to facilitate note-taking and the goal of saving administrative time for busy healthcare providers. We saw burden up there on the slide, so really the aim is to reduce the burden on healthcare providers. So these programs can use a microphone to filter out small talk between clinicians and patients and can summarize the visit into a structured medical note that they can then become part of the patient's medical file and then shared within the patient's circle of care. Typically, patients are asked for consent prior to using these types of programs. And they're becoming quite common in physician practices across Canada. As I said, it has led to some regulatory bodies setting guidance for their use. As an example, quite recently, the Ontario government published a list that promoted ways for family physicians to put patients before paperwork, and that actually included important guidance around AI scribes for clinicians. So let's stop hearing from me and let's ask the panelists. Amol, maybe I'll start with you. What do you think some of the benefits and risks of using these types of AI scribes are in clinical practice?
Thanks so much, and good morning, everyone. Really nice to be here with you all. First, just maybe by a show of hands, how many people have been in a clinical interaction where their care provider is using an AI scribe? Just like hands up. Who's had that experience? So I have. My kid's doctor was using it. I have to say it was kind of very pleasant. Whereas, the previous visits, the doctor was kind of sitting, typing into his computer. He was up and around and like standing in front of us and talking, and we had a much more sort of personable interaction. Obviously a very anecdotal experience, but I enjoyed it. I think the AI scribe experience, that's kind of what it's promising. It's promising, one, a more human interaction because people get, your care providers get untethered from their computer. The evidence tells us a couple of interesting things. So rigorous evaluations of AI technologies, this will be a theme of mine, pretty limited in healthcare thus far. But with AI scribes, there are a couple of big evaluations. The first, there's an Ontario evaluation. Big is probably a little bit generous, but about 155 primary care practices use these AI scribes. And what they found by surveying people before and after their use was that doctors reported, or the practitioners, sometimes nurse practitioners, doctors, they reported about 2 to 3 hours on average time saving of doing less clinical notes. And mainly that was after hours administrative time, because mainly our care providers are spending their time after their day doing their clinical notes. And that's really important. It's really important for clinician burnout. It's really important for the sustainability of our healthcare system. Kaiser Permanente did a 1-year study of 7,000 doctors, so that's the big one, and 2 different vendors, 2 different AI scribe vendors. So the first thing they noticed is that the vendor really matters. So these things, we should not just say, how good is AI scribe technology? It's like me asking you, how good is a bicycle, or how good is a, Apple. Well, it depends on the specific one, right? Their second vendor, which they didn't disclose which one, was much more favorably viewed than the first one. What they did find was that there's a wide variation in how clinicians use AI scribes. So there's a small proportion of clinicians who used it a lot, and and many who used it much less. The people who used it a lot tended to be the people who were spending a lot of time on their notes before they got the AI scribe. And those people had enormous time savings. But there were other people who maybe don't spend that much time on their clinical notes. As a doctor, I know there's a wide variation in practice around, some people will scratch out 2 words and that's it, right? And others have this very detailed documented note, and I won't tell you which one I am. So the point is, unsurprisingly, there's real variation in how people use these technologies and how much they give efficiency savings. But in the aggregate, at the health system, the Kaiser Permanente network level, people were saving a couple of minutes per note, which when you accumulate that over hundreds of notes over a week, it adds up to roughly the same amount of time, a couple of hours saved by a care practitioner over time. That is wonderful. That's wonderful, sort of low-hanging fruit efficiency saving. It's also not going to solve our problems in healthcare, right? But it's great. It's a good first step. I will flag 2 little concerns around this, and one opportunity, one concern. So one major opportunity about AI scribes is they change the way we think about data. This is our room is all about data. Historically, we've thought about structured and unstructured data, right? And we've thought about the ability to derive meaning from structured data much more easily. People go through and they document, okay, this piece of information has this definition. It's a blood pressure reading. So I know easily how to interpret and glean information from that. What the AI scribe does in a much more natural language way is it recognizes an interaction, a conversation, and tags each piece of information as, oh, that sounds like a blood pressure. Oh, that sounds like a symptom or a medication. So it's injecting meaning into a natural conversation, allowing us to generate some structure out of a very unstructured, free-flowing conversation. That's enormously exciting when it comes to downstream uses of all that information. But today's AI scribe tools don't take advantage of that. They mostly just try to replicate a clinical note, right? Basically create a facsimile of this unstructured document on the front end. And so if our AI scribe use ends there, we will not have gained as much of the potential out of these technologies as we could. The key is, how do we take all of that labeling and tagging and information generation that's happening on the back end of these systems and turn it into our ability to make use of information at a health system level for research, for quality measurement, et cetera. So I'm really excited about that opportunity, gain more information. The downside, or the challenge here, is what these technologies are deciding then is how to inject information into this data, right? They are deciding what information we glean. They are deciding what gets propagated into a clinical note. And the evaluations of AI scribes historically has been one of acceptability or accuracy from a fairly narrow definition, which is, how similar is this note to the note that a clinician generated previously, right? And that tells you something about the accuracy of the information. So you can say, okay, was it true this patient was on this medication, this medication, this medication? What it doesn't tell you is, what was the choice behind what was presented in the note and what was not presented in the note, right? It doesn't talk about the selection of information. There's a huge, right? We know that the note is a fraction of that clinical interaction. What are the choices being made in terms of what gets represented in the note, how it gets represented in the note? We don't have mechanisms for evaluating that at the moment, and it's really important that we start evaluating that, because that clinical note will drive the future care for that patient, right? And we know that there are things like words that are used in healthcare that undermine a patient's credibility or reputation. For example, the patient denied using this medication, or the patient could not adhere to this treatment, right? Then the next time a care provider interacts with that patient, they already have a bias about how they're interacting with that person, right? Difficult mom. I've been a difficult dad before. So how those choices are made, we don't have good metrics for how to evaluate them yet. And perhaps even more importantly, in the future world where more AI algorithms learn from the stuff that the first AI algorithm produced, those opportunities will both propagate and become more powerful, right? And so we're at a really important inflection point where we should be bringing a very holistic and rigorous view of how these technologies are working, rather than just holding them up to the very important, but very narrow efficiency gain, great. Accuracy, okay, good. But what about all this other stuff, right? What about what's being contained in the note, what's not contained in the note, how it's reflecting on individuals? So really exciting, but lots of work to be done.
Thanks, Dr. Verma. Marta, would you like to add anything on to that? I know you primarily work in the mental health space. Anything like our scribes being used in the mental health space, or anything you'd like to talk about in terms of opportunities and risks?
Yeah, for sure. So, I mean, the major thing we saw is efficiency, and you talked about that as well, and I think that's a big opportunity and benefit. And yes, they have a big place in mental health, especially because a lot of mental health data is narrative in nature. So, the way that clinicians will often diagnose patients is just based on these subjective observations of their symptoms, their behaviors, their narratives, and that basically gets documented using text. And so we have a lot of text. And then when it comes to having to synthesize that information into, say, something like a discharge summary, that is a lot of work, and it takes a lot of time. So I think efficiency is a massive opportunity in terms of using AI scribes in the mental health space. And I sort of echo all your concerns about how the AI is, making decisions about what information gets chosen and selected to be documented. And the same concerns around using stigmatizing language, although I think there's an opportunity there, and Charlotte and I have talked about this before. We all know, I don't know, I'm assuming, like, how many of you have used ChatGPT or a related model? I'm assuming a lot. So it's quite good at writing information in different styles. And so there is an opportunity there to use AI to, say, try to mitigate some of that stigmatizing language that's used in clinical notes. And that would have massive implications for overturning stigma, especially related to mental health conditions like psychosis or substance use, which are highly stigmatized conditions. But just to touch a little bit more on the efficiency point, I think someone wrote crumbling healthcare system on the slide.
Oh, I missed that one.
And I mean, we know our healthcare system is strained, and I think the consensus is it's really only going to get worse, potentially. And so what I want to know is, what are we going to do with that extra time? And so we talk about things like, spending more time with patients. More face time is a big one for sure. That makes the encounter more human. But if doctors are saving, say, 2 to 3 hours per week on documentation, I think it's important that they're not expected to take on more patients and increase the risk of burnout. And my concern is that if indeed our health system is crumbling, and I really hope it's not, that might be strong language, but if it's, in trouble, it's strained, I want to make sure that extra time that we get back does not clinicians are not expected to do more because they have these tools now. And if we don't have the appropriate clinical evaluation, so we don't know for sure that these systems are producing high quality outputs like high quality notes, if we sort of realize that our clinical environment is very fast-paced, there's a lot of burden on providers, and we just assume that these tools will make care more efficient and write good notes, and providers are relying on this and taking on more patients because there's more demand, then they can actually make things worse if we're just putting more burdens on providers because, now they have these AI tools that can help them work more efficiently. So it's just making sure that we're sort of addressing things at a systemic level and sort of not using these tools as a solution to larger problems that may exist, if that makes sense.
Thanks, Dr. Maslej. Yeah, so what I'm hearing in my very kind of non-experienced perspective is that these scribes are a very good tool in our toolbox for kind of improving efficiency and contributing to a better healthcare system, but they're not the only thing that we need, obviously. Yeah. Charlotte, I'd love to hear from you. As a patient, how do you feel about these types of scribes being used in healthcare?
So I've had a very fractured relationship with healthcare providers, and I've had things that were overlooked, like not represented properly or totally just misinformation. for example, I took my son to a pediatrician appointment. He was born 2 months early, so he had regular follow-up with healthcare providers. And I had never met the pediatrician before, and she says something to me as we're like just entering the room that was not accurate whatsoever, not true. And I'm like, how did she have this information, or where did this come from? And so, you know, like I ended up requesting my records, and like there was things that were overlooked that caused serious health implications in like my son's birth. So what I did to realize what that was just put the report summary from an ultrasound into ChatGPT, and it translated it in a way that I understood, and that identified a problem. So I see this as being really something that can kind of repair some of those relationships I have with healthcare providers. And, you know, like when a doctor's writing their notes, they're not writing everything anyways. So what they're picking out or what they feel is important is not necessarily what the patient's going to feel is important. So I think that there's like a chance for, you know, transparency with these scribes. And I feel like patients can, you know, advocate for themselves maybe a bit better when it's not having a doctor's opinion or biases behind it. I've had, you know, appointments in my past with like pain management and such, and I've had, you know, doctors say to me, like, I'm not going to give you anything because you were on methadone. Like, you know, it's just a stigmatizing sort of approach that's left me not trusting the healthcare system, not wanting to interact with it because of the stigma I face. So I feel like this is really an opportunity for myself to engage in a healthier way and more like proactive way with healthcare. So I'm excited about it, and I hope that it's going to be something that, you know, turns out well.
Thanks, Charlotte. Yeah, so I'm hearing that it can be definitely a tool for kind of patient empowerment and patient advocacy. And actually our next plenary session, you'll hear a little bit more about how a patient has actually used ChatGPT specifically throughout her healthcare journey. So that's a kind of a good prelude for that. Very quickly, I mean, Dr. Verma, you talked a little bit about where we see these scribes going in the future, because we've talked mostly about, you know, this is how they work right now. Any sort of opportunities you see for the future, how they can be improved? Anything you want to add to what you already said?
Yeah, well, I'll just piggyback off of a couple of the great points that were made. One is, I think there are a lot of untapped, really exciting opportunities. So the first is, we now have technology that can listen in to a conversation between a patient and a provider and do a lot of different things. And so to the point that you raised about, you know, improving the quality of interaction between clinicians and patients, what's really interesting, there have been several evaluations of the empathy in AI tools, and they are equally or more empathetic than clinicians in their communication back to patients, which is not that surprising when you think that the AI tools have literally infinite energy, or like, you know, well, you know, let's not get into planetary health, but that's important. But they are powered with, you know, and they don't get tired, and so they can express themselves consistently with, you know, friendly and accessible language, and we know just people are not like that. I think there's an opportunity for an AI scribe to give feedback to a clinician. Hey, did you, like, after you finish medical school, and truthfully, during medical school and residency, very rarely are your interactions with a patient directly observed. Very infrequently, right? And when they are observed, you know they're being observed. So you're not behaving how you normally behave. And as we get out into practice, we spin off and we just start forming our own habits, and we rarely get feedback. I would love to get feedback from a chatbot that said, hey, have you noticed that you're often kind of curt with your patients compared to your other, you know, like I've recorded every single, you know, clinical interaction in this hospital, and you are in the smallest percentile of the time you spend with your patients. Or, you know, maybe there is an opportunity for you to be more. So there's an opportunity for provider feedback that I think could be really humanizing for our healthcare system. So I think it's important for us to start thinking about these tools as what are the various things that they could do that we previously did not have the capacity to do. That's how we'll take advantage of them. Let's not use them only as facsimiles for efficiency, for, you know, what we're doing today. That's part of it. But I think it's also, you know, what can they do that we couldn't do before? I'll give you one other example. In a clinical interaction, doctors frequently ask patients about their symptoms, right? Okay, tell me about your nausea, tell me about your pain, tell me about, and we have formalized scales, the Edmonton Symptom Assessment Scale, for example, that has a way of, if you were to structure those questions and ask those questions and then document it all, I could produce a validated instrument for how someone's, and then I could track their symptoms over time, right, as a patient-reported measure. Well, we don't have time to do that in daily clinical practice. But that doesn't mean I'm not asking the question. I am asking the question. So now there's an opportunity for the AI chatbot to be generating patient-reported measures, right, in a way that we could validate. We could validate the way those instruments work. We could teach clinicians to ask the question in a very simple and not time-consuming way. And now we could open up the whole world of patient-reported measures and how those could be routinely captured and used to drive quality in healthcare systems. We know that when patient-reported measures are measured and used to drive cancer care, it reduces unnecessary treatments and improves patient outcomes. There's real studies showing that. And so I think these are the exciting opportunities. Let's think about, these AI technologies, all the things that they will allow us to do that we can't do today. And while we're, yes, allowing them to serve as facsimiles for clinical human interactions, like generate a note, but let's think about these other really exciting ways of using them. And maybe one last final point, which is, I think while I write. I don't know if that's true for any of you, right? As a clinician, I have my interaction with my patient, and then I sit down and I think, and I decide what to do next. And if you're going to take away my thinking, if you're going to take away my writing time, you're also taking away my thinking time. And I'm not sure that's exactly what we want for healthcare interactions. Now, that's not true of everyone, right? Emerge docs think on their feet and quickly. So, but the point is, there are unintended consequences of all these tools and of like a ruthless drive to efficiency. And when the problem is maybe a resource problem, efficiency is not always the answer. So let's just be careful of being dragged into that discourse.
Thanks, Amol. We'd love to hear from all of you now, in the room and online. So we're going to do another little slide out. But what do you all think about the use of medical scribes in healthcare? Are you excited about them? Are you worried? Are you both? We'll just give it a minute or so. Cautiously optimistic. I think that's a good kind of short summary of what we've heard from the panelists today. Bring them on. Excited. Scary if not well used. Concerned about impact on care quality, okay? Bittersweet. Unfettered enthusiasm. I do see a lot of excitement, for sure, which is good. I think that our panelists have kind of inspired that excitement in us, but with some caveats. Hammers can be scary too. It's all about how we use them. It's all about how we use the tool. A very good analogy. Interesting, a Band-Aid that's shifting our focus. Yeah, and I think that is kind of a key point, is that it is just one tool, but it's not going to fix kind of the systemic issues that we have in healthcare. They're coming in so fast, I can't even keep up. I'd love to just keep reading them, but I feel free to keep on putting them in. We are going to keep going because we're almost halfway through, I think, and we have another case study to do, and then we'll get into some audience question and answer. So thank you, everyone, for your input. It's really, really interesting. Let's talk a little bit about AI chatbots in healthcare. So I'll explain a little bit about what we mean by that, and then I'll let the panelists do their thing. But AI chatbots, any sort of really AI technology that are geared towards patient use, and these are becoming quite popular. So essentially, they're just computer programs or software applications that have been designed to engage in simulated conversations with humans using human-like language. So we see these in various areas in healthcare, for example, in the mental health space, They're being used for behavior change support, being used for patients to access health information, symptom assessment, medication reminders, appointment scheduling. And they use a couple of different technologies. They use natural language processing and machine learning to analyze user input. If you've never heard these terms before, I hadn't really, or I heard them, but I didn't really know what they meant. Essentially, natural language processing helps the chatbot kind of interpret the intent behind the user's words. And then machine learning will allow the technology to improve over time by kind of learning from past interactions. Could be learning from medical or health data and user feedback. So maybe I'll start with you, Charlotte. Would you consider using an AI chatbot for your healthcare, or have you used one in the past? And if you have, what did you think about it?
So I've used chatbots before, not specific to healthcare, but in other capacities. I think it would be a great tool to triage, to track symptoms. I think it would, I've been into Emerge before and waited a long time just to get triaged. So when you go into McDonald's now, you have the little ordering screen. Let's bring that into the triage hospitals. So I think that would be, a very useful tool. Even to speak with somebody on the telehealth line, often what they're going to say is you should go to Emerge. That's going to be, they just, are guiding you to say that, or to bring you there, that's why we're calling them, is because we don't want to go to Emerge. So it's we would have a better idea about what maybe symptoms we're experiencing and what the implications of, not receiving care might be, or what we could do about it to mitigate those symptoms, whatever. I think it's a great opportunity to kind of take charge of our own health, and not be subject to, long wait times in, Emerge, or, sometimes I get a little concerned about things that maybe I shouldn't be concerned about. It would probably ease some of that stress if I was feeling a bit of a hypochondriac. But I think it's a good tool, and I think that it should be used and implemented. And again, I'm excited for it. The one thing I will say I am concerned with, though, is the amount of different vendors that people might, choose from. It was mentioned already about, one physician using one vendor and then another vendor. So it's why are there so many options? Let's just vet them and sort out which is the best before we put them into the clinics. And then, then we don't have to worry about where that data is going, or one going out of business, or it'll just be a bit more secure, I feel.
Yeah, it's a really good point. We've done some kind of work on public perspectives around data use within the private sector, and there are concerns around profit motive, and then security breaches and where that data are going and what they're being used for. So it's a really good point, Charlotte. Maybe I'll go to you, Marta. We know that people are increasingly turning to AI for mental health support. And one of the reasons why we came up with this case study for the panel is that we came across a couple of articles about an AI chatbot that was impersonating a mental health clinician, and the individual didn't actually know that it wasn't a real person. But given your research into AI tools and for mental health, what are some of the implications of this type of technology, and how can we ensure that these types of chatbots are used responsibly and ethically, particularly in mental health care?
Yeah, that's a really good question, because it's a massive opportunity. Just thinking about how common conditions like depression and anxiety are, one of the benefits and opportunities here is just offering scalable psychotherapy. We have psychiatric medications available, but we also know that psychotherapy is an effective and enduring treatment option. But it requires resources. You need therapists, and for some people, they can't afford psychotherapy. And so it really offers an opportunity for people to receive the psychotherapy that they might need. And most people have smartphones, so the research does suggest that even people from low-income households do have access to a smartphone. So it's kind of like the vision would be, imagine having a psychotherapist in your pocket 24/7, because they have infinite energy, or what you said, but they're always available. So So that's a really interesting opportunity to explore for sure. Of course, there are risks. So, the same thing with AI scribes, the risk of sort of propagating inaccurate information. There needs to be guardrails. So, we know that the more recent GPT models that are available have some pretty decent guardrails where they won't, spew sexist and racist language, hopefully. But there's always the sort of risk that they might say something inappropriate or inaccurate. So I'll give you an example. I was involved in some research with engineers at the University of Toronto. They're trying to build a chatbot that can deliver psychotherapy for smoking cessation. So we know a lot of people smoke. They were trying to deliver something called motivational interviewing, which is this kind of non-judgmental, compassionate, therapeutic approach to help people guide them towards a decision to quit smoking. And we were using earlier versions of the GPT models because ChatGPT was not a thing at the time. And when we were reviewing the conversations, at one point, one of the chatbots had said to one of our kind of research participants, "Oh, well, you seem stressed. Why don't you have a cigarette?" And we were like, "No, you can't say that." And of course, this is an earlier version of the model. And hopefully something like that won't happen, but there's always potential for inappropriate things to be said. Now, there probably are some psychotherapists out there that might say something inappropriate to their patients. So we need to think about what the appropriate benchmark is for evaluation. Do they need to be perfect? Do they need to be as good as a human? We really need to think through how to evaluate these systems to just ensure that they can be deployed responsibly and ethically. The other thing I will say is, despite the risks, I do think there's lots of opportunities, especially for reaching, groups that might be socially marginalized. So there is some evidence that, people who may not have access to support in real life really rely on these chatbots. So I'm thinking of a study I read where, LGBTQ+ youth were using chatbots to practice coming out to their parents or friends, and they're worried about, people in their lives not being supportive of their lifestyle. And so I think if we don't deploy these things, we run the risk of not taking advantage of them and maybe taking away sources of support for people who don't have it otherwise. So we really need to think through the ethics of both deploying but also not deploying. So I think there's massive opportunity there, but I think we keep going back to this idea of evaluation, and I see a lot of comments saying we need testing, we need to figure out how to evaluate these things. And just one final point about evaluation is I do think that for us to evaluate these systems properly, anticipate all the risks, but also really kind of get a handle on what opportunities are available, is the evaluation has to be interdisciplinary and collaborative. So we need everyone at the table. We need clinicians, we need people with lived expertise, but we also need social scientists, we need anthropologists, we need experts in human-computer interaction, we need public health people, economics, just everyone get in there and think through all the opportunities and risks, because that's really how we'll get creative and how we'll be innovative.
Thanks, Marta. And I think your smoking example was funny, but it also really reminds us that the data that AI tools are being trained on, it comes from us as humans. So it came from maybe a combination of therapists who actually maybe did suggest smoking.
I really hope not.
Right? But data come from us, and with all the biases that are kind of present in our society, right? So thanks for that. Amol, do you think AI chatbots are going to become more and more common? And what are some things that we should be aware of when we consider these types of technologies, on top of what Marta and Charlotte have said?
Yeah, for sure. Maybe I'll share a little bit of the state of the art. So Google just published a paper in Nature in April, so this month, showing two new technologies. They're evolutions of previous technologies. So specifically in the realm of chatbots, it's about how these tools can interact with people in natural language, so in just plain language, back and forth. What they did was they took these AI chatbots And they had simulated patients, and they had an interaction from the beginning of the clinical interaction. So how are you feeling today? Why are you here? So from the outset to the full end of a primary care interaction. And then they randomized simulated patients also to real doctors and nurse practitioners. And they compared the transcript of the chat with the human and the AI, and also the diagnostic accuracy at the end of the chat with the human and the AI. And the AI had not received any special coaching or anything like that. It was just like a simulated patient interacting. And what they found was that the AI and the humans, clinicians, had the same quality of taking a history from a patient and engaging back and forth in terms of the information that they gained was the same. They also found, this kind of harkens back to my previous point, that the AI tools were consistently more empathetic, were actually more likely to elicit patient preferences as part of treatment decisions, so they were more likely to ask what they would want, and they more adhered to practice guidelines. And then when they landed on diagnostic decisions, they were equal. And in some cases, the AI tool was more accurate by a couple of percentage points in terms of identifying less common conditions. So look, the state of the art is that these chatbots are performing roughly at the level of humans, and this is the giant caveat, in this simulated patient environment. So the second state of the art point is that a systematic review published earlier this year looking at 519 studies of large language models in healthcare. One of the key findings of the study was that a certain percentage used real world data and another percentage used simulated synthetic data like this simulated patient scenario or some written cases. What's your guess for the percentage of these studies that are using real world data? We're here at the Health Data for all of us. What's your guess? Just like think about it in your mind. What percentage of all AI studies are using real world data versus these synthetic scenarios? 20%. We have an optimistic room. So less than 5%, okay? So less than 5% of AI studies are using, and let's be clear about what that means. Doctors and nurses do not practice by chat interactions, except for in the rare context of like the telephone thing, and then that's why it's always like go to emerge, right? We practice by having a human interaction. You get all this unconscious information about how they're dressed, what's their tone of voice, right? Like how quickly are they breathing? That changes and informs the way we interact with patients. So when we say AI is as good as the doctor, it's this very watered down version of actually human interactions, right? So let's be careful because let's also acknowledge that there is a massive industrial incentive to push these technologies forward. And maybe I'll conclude with this closing thought about, so yes, chatbots, I'm really excited about them actually. Like that tool suggests that there may be that front-end interaction to an emergency department, not just with simple triage, but like actually get your whole history and order some initial lab tests and other things so that by the time you see your care provider, we've like really dramatically improved the efficiency of the system. So super excited. But let's also acknowledge, so if I were to ask you in the room, what is the prevailing discourse that you hear about AI in healthcare today? Like, what are people talking about in AI? And you've been in rooms, you've been in conversations. We talked about privacy concerns, ethics, all these reliability concerns. But if you could think of like a single narrative, I'll tell you what's in my mind. But just like, what is the thing that you may have heard a lot about AI in healthcare? Great, really exciting. The thing that I hear every day, okay, in conversations is, why is healthcare so slow to implement AI? Has anyone heard that? Like, why are we falling behind the world in implementing AI? Why are we so slow to implement AI? How long have these technologies existed? Honestly, like step back. Like 2 years since ChatGPT was like really famously in the New York Times? Obviously there's a decade before that, but even a decade before that, right? Why is the prevailing discourse, how many randomized control trials of clinical AI interventions do you think there have been in the world? Okay, so every year there are 20,000 drug trials. Okay, every year, 20,000. Between 2018 and 2023, how many AI clinical trials were there? Just think in your mind. Compared to 100,000 drug trials during that time, how many AI clinical randomized control trials, which is the standard we hold for something to come into medical practice? 86, okay? Less than 0.1% of the drug trials, okay? So what is this technology that we are so behind in implementing that's been proven to be rigorous and safe and privacy protecting and patient-centered? What is it? The discourse is pushing us to implement. We're so behind in implementation. Why is that the discourse, right? I think we should question the discourse. And I think we should so it's unquestionably true. Enormous opportunity. I'm very bullish on chatbot technologies. But we don't have the infrastructure to develop and evaluate these tools properly. That doesn't exist. Let's urgently build that infrastructure so that then we can use these tools safely and wisely. So we should urgently do something, but it is not an urgent rush to implementation of these technologies widely. I think it's an urgent rush to, as a coalition of many people, developing the infrastructure to test, evaluate, design solutions that will work for us. And so that's what I'm really excited about.
Yeah, so moral of the story is we're very early in this adoption of AI. Like, we may not feel like it, but yeah, there's a lot more to go. Yeah. Very quick question for the audience, and then we'll actually get into the Q&A portion because I want to have enough time for that. But what do you all think about the use of chatbots in healthcare? Online and in person, feel free to enter it in the Slido. Not convinced? Okay. We haven't convinced you yet. We're not trying to.
Polarizing.
The environmental impact, and that is something, and then I think a couple of you have brought up that, and it's interesting. I've just done a planetary health course, and that really kind of made me think about kind of all of the energy that ChatGPT and these types of technologies use. I just read something recently that said that even by, say, if you're conversing with ChatGPT and you say thank you, or that you kind of add in that collegial language, the amount of energy that takes up just by saying thank you to the tool is a lot. So I think it's a really important consideration.
Yeah, maybe just on the energy. I think the energy thing is really important. It's very complicated, as people in this room, because it depends on where your energy is coming from, what the source of the energy is. There are all sorts of new technologies in the way the major cost is like the cooling of data centers, right? Mm-hmm. And so there's new approaches to doing that with liquid instead of air, and but also even just like the extraction of the minerals that go into our chips is like an extractive. So the whole thing end to end is a real challenge. I will say that one exciting thing about having large AI models is that most of the energy goes into the initial training of the model. And then if that model is used for many purposes downstream, it's a lot more efficient. So you can kind of like amortize the investment of energy over time so that you can get a lot of use out of these models with relatively little additional energy cost downstream. So I'm bullish on the energy point, but I think it's really, we don't have good ways of measuring and reporting and incentivizing around that. So.
I also just saw one about data governance. Just to plug that, one of our concurrent sessions this afternoon will be specifically around data governance and how these models may need to change based on AI and data coming from all different places. So again, keep these answers coming in, but I do want to have some time for Q&A. I think we have about 10 minutes left. So let's move to the Q&A portion. Feel free, and we're going to switch between in-person and Slido online questions. So feel free to direct your question to a specific panelist here, or it can be a general question, and then all of our panelists can fight over who answers, or you can all answer. Why don't we start with, is there a question in the room? I see Alex over there.
Thank you so much for a wonderful panel. We heard a lot about the data and about existing clinical processes, but one question that I had was, how should we structure, the prompting of models to respond to a clinical context? So in other words, are there any specific ways of prompting models that could bring in considerations like being attentive to the kind of audience you're interacting with, considerations of equity, or to the fact that information that's useful for a clinician is very different from information that's going to be useful for a patient? And then secondly, are there any model architectures that are especially prominent in this space? Here, I hear a lot of conversation exclusively about things that are used to dealing with natural language, but is there room to think about bringing in multimodal data or bringing in data that's not just language, and what kinds of either training approaches or model architectures are looking promising for making inroads into that space? I know at a meeting a few years ago by CIHR, there was a lot of discussion of, well, for instance, maybe we need totally different model architectures for biological information. So yeah, thank you again for a wonderful talk.
I mean, I can maybe start by talking a bit about the prompt engineering question, and I think it still goes back to research. And so, as we get more studies that are looking at how these models are being used to generate certain outputs. So if you take the example of using generative AI to summarize clinical notes, there's certain prompt approaches or prompting approaches that will generate better summaries of clinical notes. So we know that adding more context, adding more details, being very specific, kind of lowering temperature parameters in that context is better. Certain models work better than others for that purpose. So these are all different considerations that need testing to figure out over time. In terms of the types of models, it's clear that ChatGPT usually works better than other models in these sorts of evaluations and the few evaluations that are done. It's a large model. But I think one of the reasons why it's not being deployed on real patient data is because it's a proprietary model and there are concerns about security and privacy. So why are we still evaluating it so much? Why aren't we using openly available models to do these sorts of evaluations, models that can actually be deployed in these settings? And so I just think it boils down to testing and evaluation. We need a framework for how to do that properly so that we can sort of collectively begin to understand which approaches, which models, which parameters work best. In terms of the sort of multimodal data question, that's a really interesting one, and I don't know that I have an answer. I think considering all kinds of data and not just text data is probably a very useful thing because the more kind of multidimensional data sets that you have, the better you can sort of generate an output that you want. But I don't know that I can speak to those specific approaches.
Yeah, maybe I'll make 2 points. So one, I'm very optimistic about multimodal data. The latest iterations of, we'll call them frontier AI models, so like Google's Gemini or the GPT family, the Llama family, they're actually getting very good at handling images and language, as you know, and there are these different things like fusion architectures where you're bringing together different kinds of models, like a model that can process images with a model that can process text. Can actually, what I'm really excited about with the chatbot thing is the ability to interact with voice, so much better than, many people have some experience of interacting with like a Siri or an Alexa or something like that, right? But they're kind of annoying and they don't work particularly well, and they're glitchy. The latest versions of these tools actually work really well. You can interrupt them, they can kind of interact with you dynamically. So if we pair that with the idea of like the emerge front door and someone being able to come in, you can actually have that interaction be with voice as much as it is with just text, and that I think really will free up a lot more interaction. Can we get to other languages, et cetera? Really exciting. So I do think multimodal is an exciting opportunity. The challenges there will be related to lack of deployment infrastructure in most healthcare organizations, and the lack of sort of sufficient local compute to process all that. And I think there will be challenges downstream, but I think technologically it's where the field is moving, and it's quite exciting. I want to just make one small observation. AI models should challenge the way you think about how computers work. So we have this sense that if you ask a computer to do something and you give it the same data and the same instructions, it will do the same thing every time, right? That's not how AI models work. these frontier AI models work. So they did this study of asking AI models to pass the Israeli medical licensing exam. And they gave the model the exact same questions and the exact same prompt, the exact same instructions, and they asked it to do the exam 120 times. And the model scores ranged from 20% to 70%, depending on the time. Because there is a randomness encoded in AI models, that's kind of what gives the models their personality, their ability to interact with natural language. Marta mentioned temperature, so that's the notion of how dynamic is the model. You can turn that down, but when you turn it down, it's kind of less, in some cases, there's a thought that it's less able to do reasoning and less able. So the point is, AI models have a randomness that is going to pose a real challenge for reliability of use in a clinical context.
So do humans.
So do humans. I agree with you. So what's our benchmark, right? I think your point was right. Like, what should our benchmark be? But don't think about the AI world as exactly the same as like a computer program you're used to interacting with. There's a randomness that really changes the way we should think about these models.
Thank you all. Are we good with this question? We want to move on? Okay. I'm going to go to an online question. And I see one that's been upvoted a number of times, so I'll go to that one. So AI chatbots are notorious at not being able to handle negated information well. Are we just adding another layer of convenience at the risk of inaccuracy and yet another layer of information that needs validating? Does anyone want to take a shot at that one? You can think about it for a minute.
By negated information, I guess they mean like someone saying I don't have chest pain. Is that the interpretation? I'm not sure I totally understand what negated information means. Did either?
I sort of interpret it as like contrasting information. Like if sort of the user doesn't agree with, well, yeah, I think we would need a bit more clarity on what negated information refers to.
Yeah, and I think it probably goes back to the importance of validating the information. Like we heard the Public Advisory Council yesterday heard from another physician who uses, he's well versed in this space, and he was talking about how, actually about medical scribes in particular, and how depending on the kind of the complexity of the case, like sometimes it takes longer for the clinician to actually have to go back and review everything for accuracy than it would be to just take the notes, especially if, say, the EHR already has some sort of template that you can fill in. So I think it brings up points about validation for sure. Maybe we can move on to another online question then, if that would be, what's the next one?
If that's the case, Yeah, no, but that actually makes a lot of sense, because the concern is that, using these technologies, if they're not super accurate, would add to sort of the burden and the cognitive load of a clinician, which is sort of the point I was trying to make earlier, maybe not as, not articulating it well, but it's sort of like, my concern is that this AI will introduce more burden in ways that we can't really see. And then if we already have a strained health system and we're expecting clinicians to do more, but giving them this tool that is causing them to do more, it'll sort of make it a bit worse. So I wonder if that's sort of what that question was trying to get at is, I don't know. Charlotte?
I kind of see like a solution to potentially that problem would be like we have available to us Pocket Health, Connect My Chart. My doctor communicates through email. So just have a summary sent to the patient and they can check box or just write comments about what they disagree with. And then there you go. You're taking charge of your own health and not really worrying about what's in there that you don't know or that what could be accurate. You're proving it.
Yeah, collaborative documentation would be super cool, like extension of that technology.
Yeah, and again, bring it back to patient empowerment and hearing things about health literacy and the importance of really advocating for your own health. Yeah. How about we do go to an in-person question if there's anyone. Leah?
Can you say your name and where you're from? And stand up.
Oh, stand up. Hi, everyone. Thank you for an excellent conversation. Leah Stevenson. I'm with a group called AllCan Canada that's sponsored by Save Your Skin Foundation, patient organization. Couple quick, big questions, maybe not quick questions. Data ownership. I think it was a question that came up there too, but we look south. We're naming many of the most powerful developers and vendors, Google, Alphabet, whatever. They're American. There's huge trends going on there in terms of the data, how it's being used, et cetera. So just any thoughts on that piece of, as it relates to the various technologies we were just discussing in health AI, and that whole piece around the data ownership and the potential for things to change. And then the other piece is liability. Medical liability when it comes to a provider recommending, oh, here, use this chatbot or whatever the case may be. So just thoughts around the liability piece.
Who wants to take a...
Sure, leave me with the hard question. The data questions are very important. I think we should, and I think we are. I think our federal government is thinking about this as a sovereignty question. I think our various provinces are also approaching it this way. There is a difference between the tools we use and the data that they produce and the data that feeds them, and I think there are ways of taking advantage of the latest international technologies. I think we'd be wrong to not. But there is a way to safeguard our data around that, so that things are run in Canadian data centers with Canadian governance and ownership. I think we should be cultivating Canadian technologies in this space as well. But I think it's a really important question that a lot of people are fortunately thinking about. One interesting point recently raised in the Canadian press was that the American Data Acts, even for subsidiary corporations, so like Google Canada, might be subject to American law when it comes to its data holdings here in Canada. So I think that there are really important legal questions that probably haven't been tested in courts yet and that we have to be careful about. To your second point, which was about liability, medical legal liability. Again, these haven't been tested in courts yet. The Canadian Association of Radiologists did some really good early thinking around this and sort of thinking about how as you increase automation and things get away from human decision-making and oversight, then the liability or accountability for a model's decision-making maybe moves more towards the vendor or to the health system that procured it as opposed to the individual clinician. But I don't think we have a good framework for actually how would that look and what level of accountability do we accept. And I think we've seen with the automated cars movement some fits and starts in terms of acceptability of technology there, right, obviously. And so if we graft that onto healthcare, like I presume we're even more risk averse. I will say that some companies take enterprise risk as part of their value proposition. So, buy our AI solution and we will indemnify your hospital for using it if something bad happens, right? And that's their value, because in the world of like open source AI tools, why would you go to a company? That's one of their value propositions. And so I think there is a legal framework that could emerge from this. I'm not an expert in that area, but we have to, again, this is my point about us being really early on these areas, and there's a lot we have to mature before we're ready for widespread use.
And I will just say that at least in the mental health space or the psychiatry space, I think the current sort of consensus and the governing bodies say that the ultimate accountability of any use of AI tool in clinical practice lies with the clinician, which again goes back to this point of like burdening clinicians. Like if our tool doesn't work, sorry, that's your fault. And the health system is crumbling. It's sort of like everything kind of falls on frontline staff. And yeah, unless something's changed, but that's sort of my understanding. And again, I'm also not an expert in this area, but it seems like the liability is usually like the front end users who are busy. Yeah.
Thank you all. There's so many amazing questions. I think we're at time. Can someone tell me if we're at time? We're close to the break. Yeah. 1 minute?
We have 10 minutes.
Oh, 10 minutes? Because I don't know what time it is. Is it 10:30? Because this tells, you added 10 more minutes. Amazing. Okay, guys, we get 10 more minutes. Yes,
Amazing
we'll go to
for
online.
who?
We'll go to online and then we'll get your question, okay? Okay. How exciting. So why aren't these technologies, and I think we can assume just AI technologies in general, subjected to health technology assessment as are medications, devices, and procedures?
Exactly.
Boom.
Like, how much are we going to spend on AI scribes? Is the benefit worth it? What's our ROI? Answer the question, right? Is it better to, what's our trade-off versus, hiring more nurses or hiring more clinic staff or whatever, right? Like, especially in a public health system, we don't have a mechanism for HTA around these technologies. So I 100% agree we need it.
Anything else either of you want to add? Or
I agree.
Pretty much.
an easy answer? That's easy.
Yeah.
Okay, can we go to the room? I think you did have a question, and then go to...
Can you say your name and where you're from?
Hi, Elise Bierry. I'm from Ottawa here, and I wear many hats. I'm a family doctor. I'm an AI scribe user since February of last year, so 2024, so just over a year. Associate professor at University of Ottawa. I'm also the chair in family medicine, so I lead a program of research looking at access to care and medication appropriateness, as well as language as a determinant of health. So I see this from these many different perspectives. My question is about what about data integration? I look at our healthcare system, and I think I see the huge potential. I agree with the health technology assessment being a desirable. However, what about data integration? And I'm saying this on a very concrete background of having moved my practice after 13 years from a hospital that was using an American EMR that will remain unnamed. And I was given an Excel file with the names and addresses of my patients. And I had 13 years of clinical data. I moved the clinic out into the community in June of 2023. So it's almost 2 years now. And we have largely rebuilt the charts of the patients. We can get labs centrally. That is the one thing you can get centrally in Ontario through OLIS. I'm able to actually go and download labs. Everything else is not accessible unless the patient brings me a printout of my chart. So what about data integration? So that's one example. The other example is we get labs, the current labs are coming in electronically. The patients get their stool test done, and then somebody has to manually enter the result into the chart. So this is just a snapshot, just an example. So multiply this by thousands of primary care practices across the country. How do we use AI, or can we use AI to make this, get rid of this huge wastefulness that is going on in terms of the time that people spend and the resources? I've found a huge increase in efficiency by using an AI scribe, but I see this huge inefficiency in the other areas of our practice organization. And this is not specific to our practice. This is a systemic problem. So I know it's a big question, but I think it's an important one because we're all excited about the new things, but I think we need to fix things that are really slowing us down and making the system inefficient and burning people out.
So it's really, I think what you're highlighting is the issues we have with data interoperability. And I think Bill C-72 would have been great, the Connected Care for Canadians Act. Unfortunately, that bill has died. We'll see what happens with it. But yeah, I'd love to hear kind of how AI might be able to help with those issues.
Maybe in so just quickly, on the intersection between AI and sort of thorny problems in health data, I think of AI as sort of three things. It's a tool, and so maybe four, okay. So it's a tool that can help address the problems, great. So like AI can process natural language, maybe that'll help us move data from here and there and understand data and like standardize data better, great. The second thing importantly, it's something that shows us that a problem exists that we didn't know existed, okay? So for example, because of investigations into algorithmic bias in AI, one of the things we learned is that our medical measurement devices are biased. So pulse oximeters, okay, that measure your oxygen level in your blood work less well if you have dark skin. It underestimates low oxygen levels in people who have darker skin, to the point that for decades, we have been underdiagnosing respiratory problems in people with dark skin. That is a shocking thing to discover, and has led to new laws in the United States that all medical devices have to be tested in people of different racial or skin colors, different backgrounds, to show your device works. Okay, that's a benefit of a tool like AI or a technology like AI that's garnering a lot of attention. It can shine a light on things that we didn't know existed before. People talk about AI as a mirror, right? Like it helping us see ourselves. It's the second thing it can do. The third thing is it can create incentive structures or a burning platform for us to address problems we knew existed. So the health data fragmentation problem is a problem we know exists. I don't need AI to tell me that that's a huge problem. But as AI technologies are data hungry and people want to make new AI solutions, and there's all this interest around data in a way that there wasn't before, because before the pain of a fragmented data system fell on patients and their providers, but kind of silently, right? People are like, oh, you're just grumbling about, you have to do extra work to get that information. It wasn't well measured. Now, the pain of data fragmentation affects companies that are trying to generate AI solutions, right? And so I think it creates a burning platform for us to address. So I kind of think about those are the three ways I think AI can help us, because it's this bright, shiny object. It can help us by being a tool, by showing problems we didn't know existed, and then by creating a burning platform to address problems that we knew existed. The fourth thing, it could also distract us from important problems. And so we have to be careful not to just chase the shiny object and forget about data integration and interoperability. So I'm glad you raised it. It's like there's sort of like learn to walk while we're kind of learning to walk while we learn to run in this weird system.
Marta, Charlotte, anything you'd like to add to that question? The systems problem.
Yeah, I mean, I don't have a solution at the moment except to like empathize and say, even when I'm doing research on, say, how well generative AI can summarize clinical notes in a healthcare setting or mental health specifically, I also know a lot of the information that gets synthesized is just like collateral that you get from your colleague who's like telling you about the patient. Or there's also other systems that clinicians get their information from, like Connect Ontario, which is not linked with the health record. And so it poses a massive problem for AI systems trying to ingest all the available relevant data that hopefully will get solved, because now there's this like pressure to do so. Can I just say something based on what you said, which is this issue of health equity, which I actually study and forgot to mention. But it is like a mirror, and it can sort of show you kind of some of the existing disparities that are there. So when we talk about evaluation, I think it's super important to also evaluate whether the performance of the models or the outputs that they generate, say like summaries of clinical notes, don't differ based on the characteristics of patients and providers. If your provider happens to have an accent, will this impact the quality of the documentation? We don't want that to differ in a systematic way. But one thing I also wanted to mention was that in Ontario, and I don't know if this is the case for Canada, like a lot of hospitals don't collect the information that's needed to check whether the models are, the performance of the models is different. So like social data, health equity data is also health data. And we're missing that data to be able to collect it or to be able to measure whether our AI systems are failing some populations. Anyway, so I was like, oh my God, I forgot to say that.
That's good, Marta. That could actually serve as your closing remark, because we were going to ask you all to give us one thing that maybe you hadn't had a chance to say.
Perfect, I'll use that.
Okay, because we don't have much time left. Great. There are so many amazing questions. Thank you so much. We are going to have to start closing off this session, but I do encourage you to continue these conversations on the break. I think there's a way for online participants to network and kind of continue these conversations in person. Please feel free. I think our panelists will be here for a little bit, so catch them, ask them your burning questions if you haven't had a chance. We do have just under 2 minutes left. Marta, those were excellent kind of closing remarks. So I'll maybe move to you, Charlotte. Do you have 30 seconds of anything that maybe you didn't get a chance to say that you'd like to get across?
I think I said what I mostly wanted to say. I'm just thinking for people who lack supports, this is a very supportive tool and will help regain agency over their health and themselves. So that's.
I like the word agency. Thanks, Charlotte. And Dr. Verma, anything you'd like to close out with in 30 seconds? That's hard.
No, I mean, I think maybe I'll just double down on the sort of what I think is the most urgent point is that I think we should move urgently to try to make these technologies ready for us to use. They are getting very close on a wide variety of applications. But they're thorny problems. And so we should move urgently to create the infrastructure, the networks, and it really is about bringing together three things: data, infrastructure, and people. We need networks of those three things. You need good data resources, you need computational infrastructure, and part of infrastructure I wrap in there is governance and policy. And then people, from a wide variety of backgrounds who have the skill to use the technologies, who also understand the systems in which they're going to be used, have the lived experience of how they're going to be used. If we can bring together networks of that three kind of components, purpose-built to study, evaluate, and deploy AI technologies. And I use the term study like small s. I'm not sitting here as a big researcher. Everything needs to be a randomized control trial. But if we can do all that, I think we'll be ready to really make these technologies serve us and meet our needs rather than the other way around. And I think we should move urgently on that front.